Good afternoon. Good afternoon. If you would like to make a comment, there is a sheet over here on your left. If you'd like to, please sign up. Thank you. Good afternoon, and welcome to the Appropriations Subcommittee for Health. We're going to take just a moment and go around the room and let each member of the committee, introduce themselves. Let's see. We'll start right here. You want to start?
Hi, I'm Devin Seaball. I'm represent House District 34 in Cobb County.
Short and sweet. Good afternoon. I'm Representative Karen Bennett, representing House District 94, parts of DeKalb and Gwinnett counties, and the entire state of Georgia.
I'm Lee Hawkins. I represent the 27th District, which is Hall and part of Lumpkin County now.
Stevens, I represent Savannah, Bryan County, big chunk of Bryan County, and District 164.
Thank you, members. I'm Darlene Taylor, and I represent District 173, Thomas and Grady County. Thank you all for being here today. We're anxious to hear all that you have to say, and we have a list to begin with. Again, if you would like to speak, there is a sign-up sheet for public comment, but we will start with the Department of Community Health. If you'll come to the podium, we'd love to hear from you.
Thank you, Madam Chair.
Good afternoon and welcome.
All right. Good afternoon, Madam Chair, members of the committee. I hope everyone can hear me all right, and everyone watching at home. It's an honor to be with you this afternoon. My name is Russell Carlson. I've had the privilege of serving as a commissioner for the Department of Community Health since August of last year. And with me today is our Chief Operating Officer, Joe Hood. His title doesn't do him justice. He's been with the state for 31 years now and has worn a lot of hats and helps us navigate all the fun here at DCH, and we're honored to have him. And it's an interesting time to be presenting before you, Madam Chair, and members of the committee. As you're probably aware, there's some real-time discussions going on out of D.C. as far as federal funding and what's being put on hold, what's being released, what's going to be accepted and when. And it's something that DCH, as your state Medicaid agency, that we're tracking. In fact, we'll be leaving here should we be through with our business and it's okay with the committee. We'll be stepping out for a 4 o'clock call with Medicaid directors and CFOs of all 56 states and territories to make sure that we're current. We have gotten some what we believe to be good guidance within the last 2 hours that within this conversation of stoppage as far as federal funding, that Medicaid does appear to be exempt from some of these recent orders. But on the way over here, we confirmed that some of the portals that allow us access to those funds are in the process of being turned back on. And hopefully at our 4 o'clock call, we'll have a little bit more clarity on what that looks like. But we have reason to breathe a little bit easier just since lunchtime today. But an interesting time to be presenting the budget when a lot of these discussions are real time. We're very grateful to have a team that's active at a national level, relationships, and we have had a good flow of information as far as what is and isn't happening in D.C. So hopefully we can operate in the right way. So moving into the presentation, and Joe will be driving today. Obviously, we're here today to discuss the governor's amended budget recommendations, and we'll be back soon to talk about the broader department operations with the big budget. But getting right to the testimony today. Joe, let's move a slide, please. We always like to start with this. These are the items that you passed into law, whether an Appropriations Act or a piece of legislation that were signed into law by the governor. We always like to start here for a couple reasons. One is we just want you to know that we're delivering, executing, thanks to our board and them passing a lot of things that require some federal attention. We were able to move out in a timely fashion and get the matters that you've passed in the past session into the field. One, again, I just want you to have confidence that these things are being executed, but two, we always like to start with this slide because we always want you to know as a department we take legislative intent seriously, and we have a good debate on the issues during these 40 days, but when something's signed into law, we execute. When we respect that all day, and we try to do the best we can in a timely manner. And also a lot of things in our budget, when we're able to work through the months after session, getting them to the board, getting them to DC, a lot of these benefits and initiatives are able to go retroactive. So even if we're working on the proper rules and proper structure, proper methodology, when they are approved at the CMS level where needed, they usually are going retroactive to July 1st. So we're able to get these items into the field. Of note, I mean, you could pick out any of these. I know so many of them are important to you. You'll see rate increases, speech language pathology, audiology, PT, OT, OB increased to 2024 Medicare rates for office visits, OB care, delivery. Adult dental was a big issue. Optometry codes, biomarker testing, preeclampsia and others. I know these are important matters to you, and these are initiatives that we're able to go live, codes turned on, what have you. Continuous glucose monitoring, that's something that involved some outreach with different providers and manufacturers to get things in the field in an appropriate way. And all of those have gone into effect and are being implemented now. Moving into the base budget for the 2025, should be a familiar slide to you, the way we break things out per program. As you can see, $5.1 billion in state funds. Next slide will show you that we're just over $20 billion in federal funds, and it's also total funds, excuse me. I think it's also important to know, and we try to do this each presentation, that 97% of all these dollars go to benefits in Medicaid and SHBP. So largely programmatic in nature. We like to take pride in that number, that so much of what we do actually gets to the bedside, if you will. 97% of the DCH budget driven by benefits. The largest driver of benefits, obviously, is enrollment trends. So this is a slide that we put together this year to kind of show you how much change we've endured the past couple of years. As you all know, and I think you remember from last session, during the public health emergency, the pandemic, Medicaid roles, as far as reviewing those roles, the PHE flexibility allowed for people to get on. We didn't review those roles, so enrollment trends obviously went up to a pretty large number. And then the past administration at the end of the PHE asked us to go through what we've all called redetermination, where we had to redetermine, at that time, all 2.8 million Medicaid members. And again, so many thanks to DHS and our DFACS caseworkers who run the eligibility process. They had to review all of those cases and determine at that time 2023, 2024 status of these individuals and families to make sure that they were properly enrolled and were eligible for the program. So as you'll see, trends during redetermination, for obvious reasons, began to go downward. Enrollment went downward in that space. But then last summer and fall, we the DFACS caseworkers had to shift a lot of their work to disaster SNAP during Helene and the emergency associated with that. There are federal stipulations that go to that monetary assistance where they have to prioritize those cases in a disaster. So that's kind of labeled as disaster recovery. It's commonly referred to as disaster SNAP. So our DFACS partners need to prioritize those cases, but we are grateful to the governor's office, OPB, DHS, and they allowed us to use ARPA funds to augment a lot of these caseworkers to try and keep the Medicaid work at a reasonable pace. In other words, they were federally mandated to shift to disaster SNAP, so we're able to augment a lot of that workforce, weekend overtime, a lot of different incentives to try to keep the Medicaid pace spinning at an appropriate level. So obviously now that the disaster SNAP exercise is wound down, you're back to kind of standard procedure, if you will, where they're working Medicaid applications, both renewals and new applications. Georgia's still growing. New applications coming in at a pretty big rate. That you look at our projected base trend, which has us kind of beginning to level out for the first time in years, obviously accounting for population growth. Going into some of the program by program summaries, again, as far as the amended, the departmental administration number of $795,000, I'll go into that a little bit on the next slide. ABD, age blind disabled, obviously a sensitive population, some utilization and some trends there with drug utilization and just utilization of services in general. Had that trending even despite the enrollment numbers we just showed you. The ABD, which is to be expected given the population, did trend upwards a little bit. But again, going back to the enrollment projections, you saw the LIM, low-income Medicaid, and Peach Care decrease a little bit. Again, enrollment benefits, so those reductions are tied to enrollment trends. Again, to the $795,000 in the previous slide, much of that was due to work that, again, came from the legislation to stand up a very innovative program, the PACE program for all-inclusive care for the elderly, something many states have done. There's a lot of interest out there. There's an RFP process that we're working with DOAS to finalize. A lot of stakeholder outreach, a lot of work behind the curtain, if you will, with actuaries and whatnot, getting the rates right, getting the proper approvals on the front end from CMS. So that's a program that is stood up. It's being procured for, I believe, 4 geographic areas, Joe, right now. And again, DOAS has been wonderful to work with. We hope that RFP is kind of due out any minute now. I know this program has been well received across the long-term care community, a lot of different constituency groups. A great program that we think will service a lot of members. And with the Medicare payment model, it really stands to be a good value for the state. So much of it will be federally driven. Next slide, Joe. Again, going through some of the projections, the aforementioned increases to age blind and disabled. As you can see, updating the cost report for nursing centers, something that a policy that's been adopted over the past few years to stay current on those cost report. Some of the CMS mandated high-cost drugs there you'll see on the lower third of the ABD column. And then reductions in low-income Medicaid across the board due to enrollment, same with Peach Care, which again, a net deduction of state funds there in the bottom right. This is, I know it's a busy slide, but we kind of do this on purpose to hopefully help everyone appreciate the choreography that goes into doing something like this. Actually, in the GTA budget, in Director Thomas's budget, there's a line item in the amended, that's why we bring it today, that goes to probably the largest modernization effort that we have. It goes to the crux of the eligibility. Sorry, Joe, if I hit the screen there. it goes to the core of the eligibility process in Georgia. As we know, DFACS workers have, for all the reasons we've mentioned, have such a tremendous caseload. There's a system that we've been using for some time, and it was due for procurement, and there's a good opportunity here. Despite the lift, there's a tremendous opportunity to really bring some efficiencies, to give several of the agencies, of which there are 4 attached to this eligibility system. There are 4 different agencies that will now have some autonomy as far as how they cater their specs, if you will, to meet their customers' need and their staff's need, and to just bring some modernization to bear. We know this is a large line item, but basically it constitutes a bit of a down payment in our federal partners' eyes between CMS, the Medicaid agency, but also FNS, who oversees SNAP and TANF. The state's commitment, the state's investment in this space is needed to demonstrate to the feds that we are going to see this modernization through. And it's a bit of a down payment that will then trigger, if the planning documents are approved by CMS and FNS, this will basically give us the green light to really begin implementing this program, and it will therefore lock in, almost like a mortgage rate, if you will, it'll lock in a lot of that favorable match at the federal level. In some instances, that's 90-10, some of it's 75-25, some of it's 50-50, depending on the functionality of that particular space. It's very choreographed across multiple agencies, but they do get a chance to kind of write their own destiny, if you will, and meet the needs of their own customer base. It's less monolithic, if you will. There's one big system. Here it is. Everyone gets to kind of control their own space a little bit. It's a tremendous amount of opportunity. It's something the state had been talking about doing for a long time. I think it helps a lot as far as eligibility on getting applications processed in timely fashion. But that also touches all your districts, not only from a constituent standpoint, but a lot of your providers. A prompt workflow of those applications helps them with members in their facilities that are approved, and therefore the payment should flow in a little bit more efficient manner. There's just a lot, in times of backlog, there's a lot that providers are faced with, just people outstanding. They haven't been approved yet. So hopefully this will alleviate a lot of things. It's the single biggest, as I mentioned earlier, modernization exercise that we're going through. Multi-year, as you would imagine. It's about a 2027 runway, but we have a plan that has not only been accepted by CMS as far as timelines and nuances. In many instances, our CIO, our Chief Information Officer, is asked to present to other states in the spirit of best practices. So it's a very choreographed exercise, and we're very grateful to all of our sister agencies that are going through this process with us, and we're optimistic that it manifests like just real results for you guys, for the constituents, and also the providers. So as far as the items in the amended budget, ma'am, that should probably be the gist of my presentation, but obviously I'm more than available to answer questions or anything beyond the presentation today.
Thank you. You do have a question. Chairman Hawkins, do you have a question? No. I'm sorry. I'm
Dodged
sorry,
one there.
Carolyn, it was you.
Yeah, that's right.
Sorry.
It was me, Mr. Chairman. Thank you, Madam Chair. My question has to do with the modernization that's going through. How will it manifest itself to the ultimate customer? Will they see disruptions, or will it be seamless behind the scenes? Or
That's a very good question. It is our goal to go through a period where much of this is tested behind the curtain, if you will, and just it should go live at a set date, hopefully 2027, where it's our goal, obviously, to do this with as little disruption as possible. And I think our team, through other initiatives that we've worked on, we do a good job of being honest with ourselves and not going live until we're ready, because as you've seen with other large systems that get rolled out across any number, when it goes wrong, it goes really wrong. Just look at kind of what we're dealing with today, the outset of our, some of the moves being made. We're experiencing some unintended consequences and a lot of uncertainty out there, even as of this morning, as far as what's happening and what isn't. So that's a fair question. We're going to be very methodical, and when we actually roll that out, a lot of instances like this, we actually bring in stakeholders for a bit of a test drive, if you will, beta testing. The Katie Beckett program, for example, which I know is very important to a lot of you guys, we're implementing some new case management software there to hopefully a better flow of applications and those backlogs. And we're actually working with stakeholder groups to literally give them access to the portal and just basically let them apply for these services and let us see what works and what doesn't in a safe environment. So I'd love to always promise you that nothing to see here, it's a big lift, but I do want you to know at the outset we have a healthy amount of respect for what a lift that is. And or an uncertainty, prolonged uncertainty in the field will only undo while we're in this and while we're pursuing it. So we're going to do our best to pull it off, but we have a lot of respect for what it could mean if it doesn't. So.
Thank you.
Representative Buckner, you have a question?
Yes, I do. You alluded to it, and I, of course, have heard something about some of the federal funding freezes, and I was just wondering, have we heard anything specific about any of the Medicaid payment systems in Georgia and how they might be affected or if they've been affected?
No, great question. And I meant it quite literally in the space between, kind of mid-morning and lunchtime, we did get some guidance that said Medicaid should be exempt from a lot of these moves. But obviously, like I alluded to, the 4 o'clock call with all the states, we're in a bit of a trust but verify mode. But we have a lot more comfort than we did even earlier today. And it was just the uncertainty. But they credit to the President's Office of Management and Budget, OMB, up there. They issued some clarification documentation along with Q&As, for providers, for us, to kind of clarify some of those positions. So we feel a lot better about that than we did even hours ago.
Thank you.
Yes, ma'am.
Thank you. You don't need any Rolaids now, right?
I wouldn't. I keep a stash, so if you have some, I'll need them at some point.
Thank you. Are there any other questions? Thank you for your presentation. We appreciate it.
Thank you.
Okay, if we could next have our Department of Public Health Commissioner Kathleen Toomey. Thank you. If you would introduce yourself
Yes.
and
Thank you
begin
so
your
much.
presentation. Thank you.
Thank you so much, Madam Chair. Nice to see you all, and it's good to be back. And I wanted to thank you all for all your support over the summer as well, because many of you had a chance to talk with over the course of the
Yes, bring the
Okay,
mic a
over
little
the
closer.
course of
Thank
the-
you.
the interim. I have similar uncertainties that Commissioner Carlson had, and we'll get to that in a minute. What I did want to do is begin with the beginning, because I have begun every one of my budget presentations to you since I arrived on the scene with this slide. Whoops. This, by the way, is Will Bell. He's my CFO. He also is more technologically advanced than I am. And, but he needs the equipment, so he has the equipment now. So we're moving right along. Many of you are much more, know more, as much about our structure as I do. But just a reminder that we have an unusual structure in terms of health departments around the country, because we have our state office, which oversees the 19 health districts, the health directors, physicians, who are my right-hand people in the districts overseeing county health departments, which actually are independent of the state. So it makes it a challenge at times to implement in place consistency, which is what I think we are all working to achieve for the 11 million Georgians we serve. Next slide, please. This is the budget I had in my presentation from the beginning, and I've always said our budget is about 50% federally funded, 50% state, and let's focus on the state. I do have to focus a little bit on the federal because that is in the news right now. We have not gotten word what the impact is. The majority of our federal budget comes from USDA, and that's WIC, really more than half of our federal funds, and so we're waiting to hear about that, as well as the other half largely is from HHS. So that's CDC, HRSA, that's what funds our maternal and child health programs, Ryan White programs, it's what I consider very important, essential health programs that serve our state. And so we're waiting to hear when that freeze will be lifted, and we're waiting word from our federal partners as well as Office of Budget here, the Budget Office here, OPB. And so until I get that information, I won't be able to give you additional impact. And I don't have a 4 o'clock call, so like Commissioner Carlson does. But I will be moving very quickly through this because I think these are very simple additions. Next slide. I say that every year, that I will be very quick and that I never am, but I'm relying on you, Madam Chair, to just give me the high sign and I'll be done very quickly. But the first thing is, first of all of these actually are being done in a sense to improve administrative efficiency across the state, because these moves largely, one from DHS, this first one, another one from DCH, really help. It makes sense to be moving it into our agency. It's level funded from one agency to another. It will continue into next year. For example, the first one is a budget neutral, which is funding Alzheimer's and brain health awareness campaign. This was in DHS. They had not had the contract. We have existing contracts with Emory and Brain Health. Many of you know Alan Levy, who runs that center. And it made more sense to piggyback onto our existing contracts than to start a new contract with DHS. So this will continue into next funding year as well. The governor has also requested that we look at funding a study to look at the impact of social media on the health of adolescents and children. I know there's been a lot of discussion about that. There had been certainly interest in many departments in this, including DBHDD and Department of Education. Again, it made sense to put the funding for this one-time only funding this year to work with both our UGA and Georgia Southern. So it's USG institutions that have existing researchers working on this to build on that work being done. And these funds will pay for an epidemiologist as well as research assistants to help collect these data, which will be this one time only, that once the report is generated, we can share across all the agencies with an interest in the health of children and adolescents in particular. And so that is the only thing that doesn't continue in next year's budget as well. And the last thing is the low THC program. And this is funds that will actually be budget neutral because the funds collected in this program will go back to the Treasury. And I want to just tell you that when I stood in front of you the first time about this program, you were receiving a lot of complaints. And I tried to address them as best I could. But we have really addressed these programs in a way, thanks to your support. With an epidemiologist now on board, we have accurate numbers, and we get those weekly and share them with the Cannabis Commission as well as others that need to know. So we're able to track and monitor very, very closely how this program is moving forward. And so that was thanks to you. Also, the legislation that passed last year that recommended that we not use the health departments to distribute these cards that we generate. actually was also extremely important to improve efficiency. I realized that there was a, how do you say, there was a roadblock for many people getting to these health departments that may not be easily accessible to them or their caregivers. We also saw that there may be a holdup in how these were being transported and handled by the health departments, and the health departments were collecting the fees. With this change in the state kind of centralizing the system, we were able to put a portal in place to allow these fees to be generated and rolled back into the treasury. So it's a budget neutral item. It also, the cost of the card increased by $5 only. So it's $30 rather than $25. But you buy, it's now 5 years instead of 3. Buy 3 years, now buy 5 years for only $5. So it's really quite a much better, I think, investment for the state to have put that portal in place, which actually is budget neutral for us as well. And then we can, are able to distribute it. The other thing that happened, in part because of our discussions last year, is that I asked that any complaint about the program be sent directly to me. And so if there's any holdup in getting these cards out, I would follow up personally. And I have. And the complaints have really diminished over time. And what I'm seeing, which is really interesting, is that part of the problem has to do with maybe physicians not completely filling out the form. And we can help with that. We're working on that already. We're working with Composite Board, DCH, to be able to get better information out to physicians who are enrolled as to how to fill these forms out first and accurately, so that we can also, thanks again to your support, mail these out directly to people's homes. And so that's a good news story, which will continue into next year. But it is thanks to your support for all these improvements. And that concludes my presentation for now.
Thank you. I don't know if any of the members of the committee have a question. I have a comment, and I don't think it's really a question, because our state went from hurricane to snow in a month, and you were obviously prepared because we have not had any major episodes, and I do appreciate that. And I felt like you did a very good job. Thank you.
We have a wonderful team that works on this,
Thank you.
and I appreciate all of them. Thank you so much.
Okay, our next presenter will be Chet. You're coming up for the Georgia Board of Healthcare Workforce. Are you ready? Thank you.
Hello, good afternoon. Can everyone hear me? Great. Thank you for having me. Thank you for allowing me to present. Very much appreciate this. What I'd like to do is just take a brief moment and provide a brief refresher on our agency, and then I'll get into the well laid out recommendations from the governor for our amended budget. We are the Georgia Board of Healthcare Workforce. We are an administratively attached agency to the Department of Community Health. We are most commonly known for administering loan repayment to a variety of healthcare practitioners, including dentists, physicians, physician assistants, nurse practitioners, and nurse faculty is a new one for us, and that's been a very popular program. And then we will actually later this week be approving our first round of behavioral health loan repayment awardees, so a lot of good things going on there. We also are responsible for publishing a lot of the data for the supply and distribution of healthcare practitioners around the state. Historically, we have done physicians, dentists, dental hygienists, pharmacists, and we are actually working on a very robust platform for nursing, optometrists, and more that are being charged through HB 1013. So a lot of good stuff in the pipeline for us in this upcoming, let's call it, as we finish out the fiscal year, but through the calendar as we head into next year as well. And then we do administer a lot of grant programs for graduate medical education exploration, nursing school expansion, and other things. So at a real high level, that's who we are, what we do, and we really enjoy what we do. So thank you for allowing us to do what we do. With that, the governor's recommendations, and I've laid them out by each of our programs, is first is our administration program, and that's, you know, us, our staff of 10, and the stuff we need to do our jobs. And in here, there's a recommendation to reduce funding of $120,000. That is in line with the HB 1013 online data set for the 5 boards. That's the Board of Pharmacy, Board of Nursing, Medical Composite Board, Psychology Board, and the Board of Marriage and Family Counselors. We've been able to, we are slowly spinning that thing up, and we will have data live actually this calendar year. We've had to manage 2 different licensing softwares through these different boards I just mentioned, and some other IT nuances, but we are definitely looking at a lot of light at the end of the tunnel. We might even have some data online as soon as late in the session, but likely during the summer is probably what I'm thinking right now, assuming all the tech things work to plan. Our next program is our graduate medical education program. There were no recommendations from the governor for that one, so I'll move on to the next one. The next one is the Mercer School of Medicine. There was a recommendation to provide funds to replace and expand the existing Mercer School of Medicine building, and the amount was $25 million. Moving on to the next program, we also have the Morehouse School of Medicine, and that is provide funds for a new academic building for the Morehouse School of Medicine. That is also for $25 million. Then the next program is our, what we call Physicians for Rural Areas. It really is all the loan repayments. It just got titled Physicians for Rural Areas. So these are the physicians, the dentists, the nurse practitioners, and the physician assistants. This is more of an accounting. This is not a net new. What you'll see is they're bringing the funds in from a different program. And this is just to keep all of our loan repayment dollars within the same program. So this is a $250,000 reclass. And then I'm going to move to the next program, and you'll see the $250,000 coming out. So again, no new funds, just cleaning that up. And then outside of that $250,000 adjustment, that really is all of our budget. You'll see the original, the governor's recommendations, and then the recommended in the final column on the right. If there are any questions, I would be more than glad to do my best to respond to them at this point.
I don't see any questions from the committee, and I appreciate your presentation. Thank you. Now we'll see if there are those from the audience that would like to come forward. We have some Georgia Corps folks. Are y'all together? Okay. Kim and Suni. Okay. Answer questions. Thank you. If y'all will introduce yourself and who you're representing.
Hi, good afternoon, and thank you so much for giving us the opportunity to speak. My name is Kim Jate. I live in South Forsyth County. I think I'm in District 100, and David Clark is my representative, but I'm not really sure. Things keep changing on the site, so I'm not sure. But we are here, Sonny and I are here to represent Georgia Corps and their request for $250,000 in the amended budget, and that's for a program to create awareness about the signs and symptoms of colorectal cancer in Georgians, especially for those under the age of 45, which is the current screening age for colorectal cancer. So just a quick minute about myself. I'm a stage 4 colon cancer survivor. I was diagnosed 5 years ago at the age of 47. I have endured surgeries, treatments, radiation, and you name it, and I'm now cancer-free and off treatment completely, so that's really exciting. Thank you. But, you know, the key thing for me is that, you know, I was 47 years old. At that time, the screening age was 50. People don't know the signs and symptoms of colorectal cancer. They, you know, think it's IBS or, oh, I need to lose weight. That's why I'm having stomach issues. Like, people don't go to the doctor about this, particularly young people. And I think one of the biggest things that I've seen in my cancer journey, dealing with others who are survivors and in some cases caregivers because their loved ones have passed, is that it's younger and younger and younger. People in their 20s and their 30s getting diagnosed and being at stage 4 and not getting to see a marriage or a child or any of those things. And so when I look at what can we do, like there's a lot we can do, right? I'm scared to death about all the funding of, research, because for me personally, I have a genetic cancer. And so that even my dad's doctor knew he had that genetic mutation, but didn't tell me because I wasn't 50 yet, so it didn't matter. It definitely mattered. And I could have endured way less had that doctor. So we're talking about a physician who isn't even giving the right guidance. So awareness, talking about it, getting people out to communities that don't have any idea what this is. One of my good friends in the colorectal cancer community lives out in Elberton. And she said she had never heard of colon cancer when she was diagnosed. How is that possible? How's that possible? Like, hopefully we eradicate it and it never comes back and we don't hear about it. But that's why we're here to ask for you guys to take a look at that. By 2030, the deadliest cancer in people under 45 will be colon cancer. And it's preventable and it's treatable. But awareness is the first step, and education. So I hand it over to Sunny.
Hey, I'm Sunny Lazo. I live in Alpharetta, Georgia, which is also South Forsyth. I was diagnosed at 43. I was a teacher, a kindergarten teacher in Fulton County, and I saw signs and symptoms, but I didn't realize they were signs and symptoms of colorectal cancer. And so just like Kim, chemo, radiation, surgeries, an ostomy, pelvic rehabilitation, a 2.5-year medical leave. I'm just now back to teaching public school, but online, because it's really too hard for me with side effects to be back at a school all day. But Kim is right. By 2030, it will be the deadliest cancer of people under 45. And it is it's preventable, because if I had gone in earlier and known the signs and symptoms, it would have been a simple polyp removal. And I'd wake up and they'd go, we got it, but people don't know that. They don't know the screening age. People do still think it's 50 years old. So I tell everyone I know it's 45. If you see any weird symptoms, tell your doctor. I will always credit my primary care physician for saving my life, because I wasn't, I was 43, and she sent me to get a colonoscopy. But we just want to let as many Georgians know as possible the signs and symptoms, and that's why we're here speaking on behalf of Georgia Corps and asking for $250,000 in the budget so they can launch a campaign. Thank you.
Thank you. I don't see any questions from the committee. Thank you very much. Our next presenter will be Brian Schroeder.
Good afternoon. First, I want to say thank you to Madam Chair and the committee members and the rest of our community partners. There's many people in the room who Side by Side is a part of. My name is Brian Schroeder. I'm from Decatur, Georgia, and I'm the executive director of Side by Side. We're Georgia's only brain injury clubhouse. We were founded by Shepherd Center 25 years ago. Shepherd Center recognized the need for an independent nonprofit that after someone with a brain injury goes through trauma care, goes through rehab, that there's a place for the long-term needs of men and women who've experienced a brain injury who can't return to work yet. They might not ever be able to return to work, but they need a place that can give them purpose. They need a place that can give them community. And today I'm asking you, or for this committee, to respectfully consider a $300,000 in support for Side by Side. Side by Side is one of the only day programs for men and women who've experienced a brain injury that are facing the long-term consequences. We serve, even though that we're located in Stone Mountain, we serve men and women from across the metro Atlanta area, including, and also beyond, so including Griffin, Suwanee, Cumming, and Macon. Side by Side, the easiest way to explain it is we're a soft landing place for men and women who've experienced brain injury. And for over 10 years, the state of Georgia has recognized our importance and has been a supporter of Side by Side through the budget process. In 2022 and 2023, the state of Georgia recognized Side by Side's vital commitment and vital service to our community with a gift of over support of over $250,000. Unfortunately, last year, even though we were approved initially for $300,000, the funding fell through in the last days of legislative session. Not only was Shepherd Center a founder of Side by Side, it's also a continued supporter. And while he couldn't be here today to share this message, I'd like to read a couple sentences from Jamie Shepherd, who's the CEO of Side by Side. Side by Side's purpose-driven recovery program places focus on vocation, service, and self-determination, and is considered in our industry to be best in class. Side by Side is nationally recognized as a leader in brain injury recovery, and we are fortunate for their life-changing and lifelong brain injury services in the greater metro Atlanta area. The support of over $300,000 helps to keep the doors open at Side by Side at a critical time in our program's history. Thank you very much.
I don't see any questions. Thank you for your presentation. Next, we have Ray Williams.
Thank you, Madam Chair, members of the committee. Before I begin mine, I'm with City of Hope Cancer Center, and I just want to echo your comments, and whatever we can do to help you in that request, we'd be happy to do so. But I'm here today to represent an organization called American Research and Policy Institute. They are a consortium of health economics and physicians and educators who have been working along state government, CMS, commercial health plans to analyze Medicaid data to try to eliminate fraud, waste, and abuse. Collectively, they have analyzed over 100 million lives and about $15 billion in claims data. This organization has representatives that have served on as chief health economist in the Reagan administration, in the Trump administration, and in the program integrity unit at CMS. We have given a proposal to the Department of Community Health to move forward with this fraud prevention program. It would be a 90-10 match, a one-year pilot project, and the ask is $685,000 to get the program started. The data from this can be broken down by provider level in a way that DCH has not ever had that kind of data. It can also be used for the rate setting process when the CMOs look to add the ABD population in a couple of years. We think this is another tool that the department can use, and we appreciate your support. Answer any questions.
I don't see any questions. Thank you very much for bringing this.
Thank you.
Next would be Adam Webb.
Hi everyone, my name is Sydney Wilkins and I'm the Director of State Affairs for Emory. Just going to introduce to you our COO of EUHM, Dr. Adam Webb. He is a neurointensivist and actually did his undergrad and his medical doctorate at Emory, as well as completed his residency training in neurology and fellowship training in neurocritical care at Emory. So we've got a, triple star Emory to present to you today. So he's an educator, administrator, former researcher, and clinician. And he's here today to present to you our budget ask, which we are requesting a one-time $10 million investment in state matching funds for mental health beds and a ED expansion at EUHM.
Great. Thank you so much, Sydney. Thank you so much, Madam Chair, and to the committee for having me here today. So I have the privilege to talk to you about Emory Midtown. And so Emory Midtown really provides vital services, both in ensuring the medical safety net of the metropolitan area, as well as to the state. And so a hospital has stood between the peach trees since 1911. Many know it as Crawford Long Hospital, and more recently as Emory Midtown. Though a lot of people don't actually know what goes on there and the care that's provided. And so one of the things that usually hits people particularly close to home is that if anyone in this building today had a medical emergency, chances are you would go to the emergency department at Emory Midtown. We have Grady that's right here as well, and if you had a trauma emergency, certainly there. But the vast majority of medical emergencies within the city, certainly within this area, go to Emory Midtown. The other thing a lot of people don't realize is the important role that Emory Midtown plays in the state of Georgia. So we have a number of services that support healthcare providers really across the state with providing the type of care that is both expensive and complex to provide. And so we, in addition to our high-risk maternal health programs that we have, we also have complex spinal surgery programs. We have one of the largest and most comprehensive head and neck surgery and skull-based surgery programs in the state. We have the Winship Cancer Program that's there. We have a tremendous structural heart program that trains people from across the world in life-saving techniques. And so in a lot of ways, we really are providing that mission to the state. My role as the leader of Emory Midtown is to try to make sure that we can preserve both our legacy community-facing mission as well as our complex care. It's almost like two hospitals that are combined that are there, and making sure that we have the resources to do both of those. And so we've been challenged, as many who are familiar with emergency care, certainly in the metropolitan area, know. In 2022, when Atlanta Medical Center closed, the hospitals certainly in this area have seen a huge influx of patients. And so we have seen a 45% increase in patient volume since 2022. With the abrupt closure, we tried to make some accommodations to handle this. We put up 2 temporary structures. If any of you have driven by on West Peachtree, we've got 2 temporary structures that have stood out there for 3 years now, and we have been keeping them full all the time with patients that are there. One of the other missions that Atlanta Medical Center served when it was still there is it treated a large population of mental and behavioral health patients, and so we have gone from seeing, or having on average 1 to 2 patients that are in our emergency room that are waiting for transfer to an emergency receiving facility to sometimes up to 10 to 12, and we don't have the specialized rooms that are necessary for treating those patients, and it pains me every time when I walk through there, because our safest way of caring for those patients is on stretchers in the hallway, and that is, if you're in a mental health crisis, you can imagine being in a stretcher in a hallway in a busy emergency department is only exacerbating that. It's not starting the healing process, and so. We're excited. We have committed so far approximately $11 million to expanding our emergency department and being able to meet the needs both of the community and trying to prevent those community-facing needs from impacting our ability to provide more of the complex care. And as a part of that, we are also planning a 12-bed mental and behavioral health unit that will serve as an emergency crisis unit and really allow us to provide the care that we want to provide to meet this mission that we have had to quickly pick up over these last couple of years. And so I thank you for any support that you can provide us in that. And I'm more than happy to answer questions about our role, what we do both in the community and the state.
Thank you very much for the presentation. Do you have more information?
I would.
Thank you.
You know, I'm always going to have something to say. It's just kind of my personality. My name is Sheila Humberstone with Stonebridge Consulting, and I am so fortunate to be able to work with Emory on this project and on so many of the other things that they get to work with you all on. I'm going to age myself now, but I think I'm safe in this room. I'm old enough to remember the Atlanta 1996 Olympics and how much that changed, not just Atlanta, but it changed how the world viewed our state. And we have another spotlight on our state coming shortly with the FIFA games. And we have trailers that we're seeing patients in, and that's not our best foot forward. And if it was up to us and we knew in advance that we were going to have a closure of a neighborly hospital, then we would have been able to plan for that and we would have been able to account for that, and we wouldn't have patients being treated in trailers or in the hallway. That's not our best foot forward. It's not the view that Georgia wants to have on the worldwide stage. And so what we're requesting for, we don't come and ask for one-time capital funds ever from you guys, but this is an extenuating circumstance, and we're asking for that help so that we can can provide those services in time for those big worldwide events that are going to be here. Otherwise, it's going to take a whole lot longer to get there. And frankly, with the growing population, I'm not convinced, Emory may have a little bit more confidence, but I'm not convinced with the population growth that we're ever going to catch up because the population and the needs continue to grow over time. I do have some one-pagers that I'm happy to pass out, but certainly we're here to answer your questions today or as you consider this going forward. Thank you so much.
Thank you very much for the presentation. Yes, thank you. I don't see any questions, but thank you very much for your presentation. Thank you. Our next presenter will be Terry Coleman.
Chairman Taylor, members of the committee, thank you so much for allowing me to kind of a spontaneous appearance. I want to bring something to your attention, and hopefully we can put together somebody to talk about it in the near future. You know, there's a difference, there's a thin line between meddling and doing good, and I'm hoping this is doing good. But I represent a couple of hospitals in Georgia who want to do graduate medical education programs. However, the incentive is just not there. It's tough to start up a program, a graduate medical education program. Even in the primary care residencies, it costs between $125,000 per year per slot to $150,000. Having said that, let me go back and talk to you a little bit about where we are and how we are, I think, maybe not making the best of our contribution to medical education. There are people on the street, in the legislature, and even in healthcare that might not know that when you graduate from medical school, you may have a degree, but you're not able to practice medicine. You're not able to practice medicine until you become a physician, meaning do a residency program. And in almost every case in the state, unless you unless you are board eligible or board certified, you cannot practice and quite frankly get reimbursed from Medicare, Medicaid, or many insurance companies. We have approximately 700 graduates of medical schools in Georgia: PCOM, Emory, Morehouse, Mercer, and Trinity School of Medicine. 700 who graduate. Guess what? 50% or less of those people, of those graduates, leave the state to do their residency program. Of that, the generally accepted number is maybe as much as 50% of those never come back to Georgia. Never come back. We're putting money certainly into graduate medical and medical education. We're helping Mercer, we're helping Morehouse, we're doing scholarships, but we're not effectively putting the money where it ought to go. In 2013, I believe it was, Nathan Deal, then Governor Deal, put about $20 or $30 million into an incentive program. His goal was to create 400 residency slots. He actually created over 600. Now, for people like us, out of 600 residency slots, only 12 of them came south of Macon. We have a chance. I think the governor made a stab at it this year, but he didn't complete it, or he didn't get the right information, or he didn't go far enough with it. But we really need to sit down and try to find a way to create some more residency slots so we can keep the graduates of medical schools in Georgia to stay in Georgia. We want to incentivize the hospitals, but we also want to give medical school graduates in Georgia an opportunity to do a residency in Georgia and stay in Georgia. Now it's something, I don't know if it's a question or a request or whatever, but I want you to think about it. I'd be happy to sit down and talk with you about it, whatever you might want to do. I'd be glad to try to answer any questions.
You do have a question. Chairman Petrie?
Yeah, well, thank you, Mr. Chairman. Mr. Chairman, Mr. Speaker, I just want to tell you that I love what you're talking about.
Good.
It resonates well with me. We've been trying to do this here in this body for years, and incrementally we're doing that. But we have a new medical school, as you know well now, in Savannah. And so, yes, we need not only a medical school, but we need more residency slots for those young folks coming out of medical school down in Savannah. So I'd love nothing better than to support
Well,
you
as
in
you
any way
know-
possible and throughout South Georgia.
Yeah, as you know, Memorial University Medical Center in Savannah has a very robust residency program.
Yes, sir.
However, across the street, Paul Hinchy and his folks have not been able to justify doing that because they don't have the money, the startup funds. So just for those who don't know,
That's correct.
Medicare will reimburse hospitals who do this. They'll reimburse them for actual cost, $125,000, $150,000 per slot per year, but they have to graduate their first class after 3 years. And a lot of hospitals cannot front that money, and that's the problem. So thank you.
Yes, sir. I'd love to see it at Candler St. Joseph's as well as Memorial.
Oh, yeah,
there in
it'd be
Savannah.
great.
So thank you, sir.
Now, Representative Hawkins over there, Chairman Hawkins, he benefited greatly from this. He got 150 or so slots up in Gainesville. It's been very effective. And for those of you who don't know, every physician, directly or indirectly, when they go into practice, creates 15 other jobs. So it's an economic development issue in addition to a health issue.
Thank you. And shows up in rural communities even
Yes.
stronger. It does. So I think it's a great idea. Thank you.
Thank you. If I can help you, let me know.
Thank you. Are there any others that wish to speak? Yes, please come introduce yourself and give us your issue. Thank you.
Hey, Madam Chair, I apologize. Amy Hughes, I did not get to sign up on your sheet ahead of time. I just wanted to express my full support for the PACE program that the DCH Commissioner talked about, where I represent Hospice Savannah, who is really looking forward to applying to have a PACE program down in the Savannah area. And we just wanted to mention, since this is the appropriations side of things, that last year the General Assembly was very generous, including some planning grants in your budget. And I believe 3 grants of $500,000 went out to nonprofit entities that would be planning to apply for PACE. And so that's wonderful. And I would just encourage you to consider adding more as a possibility for the entities that are selected to be the PACE providers, because the cost to start up a program for our group in Savannah is going to be about $8 million, because you have to renovate facilities and hire a whole bunch of folks and all of this. So it's a lot to take on up front. So if you find any available funding in the either the FY25 or the 26 budget for those entities that are selected, I think that would be a wonderful thing to do. And thank you to Chairman Petrie for his efforts in passing that important legislation last year, because it's really going to make a difference. Thank you.
Thank you very much. Are there any others that would like to speak? Any comments from the committee? That completes our meeting, and we are adjourned. Thank you.